to me, this is a real success of UCL, and so many things happen in UCL that are really, really superb. And in TB, when we're doing something like this, and most people probably aren't aware of it, I really wanted to celebrate this. So thank you both of you for coming here and telling us about this global individual. I'll stop.
Thank you very much. And I have just been out to check that there is wine outside. So if people start to sort of drift off during the talk, I'll understand. So this is going to be me and Stella giving a talk, and it's about a new venture that has been going for about a year. And in this short time, I want to introduce the project, how it's being set up at UCL, talk about how we handle the data and some of the issues that arise and what might happen in the future. And so I suppose it starts with the fact that we know that TB treatment is complex. We treat people with lots of drugs for a long time. There's resistance and there's side effects, but the whole landscape is changing. So how we treat all the different sorts of TB, how we treat children, and in quite a dramatic way, the classic regimens that we've all been familiar with for a long time are being changed. And these are through trials that many of us know very well, and others. And so the change of guidelines that comes initially from these trials is then cemented by the WHO looking at individual patients' data. And they look at a mixture of trial data and programmatic data, which comes from, for example, national TB programs. And here, for example, is an announcement in May from WHO talking about key changes to treatment of drug-resistant TB. And the premise of this project is that pooling data sets increases the power and adds value. And this is done by bringing the data together in individual patient data collections, or IPDs. So we have had TB IPDs in the past, and in particular, there are two IPDs that have been set up by Dick Menzies at McGill University, and he, over the last 10 years or so, has set up two IPDs, a total of 84 data sets brought in, 13,000 records, and he carried out meta-analyses with the data contributors, and using these IPDs, he showed various effects that were not visible if you were just looking at the data sets on their own. So it showed that the power and what you could find out, this was a valuable approach. And not only carrying out these, he also worked with the WHO Guideline Development Group in terms of informing what treatments should be advised. And here he is after one of his meta-analyses was published. This is a news item on this. And this is one of the papers that came out of it. This is the earlier one on 10,000 patients. And you can just see a lot of data contributors here who supplied their data sets for this particular project. However, although this was a really valuable venture, it was limited in the sense that people outside McGill could apply to do research themselves, but they could only do it by turning up and working physically at McGill. So in response to that, WHO decided to try and set up an IPD that was more flexible, that was more accessible to researchers. And so in March 2021, they put out a call for people who might be interested in working with them on that. And Lele Rangarkar and Angela Crook put in a bid. And this was a bid from UCL, and it was badged as UCL TB, and I think it might be the first project that was actually badged in that way, so that was good. And it included all the expertise at the MRC Clinical Trials Unit, Institute for Global Health, and Centre for Clinical Microbiology. So these people were all listed on the grant, and as well as the academic support expertise, we have the systems and infrastructure at UCL. So we have all the institutional support covering data storage here, which we'll be talking about later on, data curation, data governance, legal services, and the contracts managed through UCL consultants. And to our great pleasure, we were awarded the contract for this for the first 5 years. And this is the WHO announcement that UCL have been awarded this. And this is the way it's been working. So a small group of us over the last year or so have been meeting regularly. That's the two PIs, Lele and Angela, the two people who are paid to do some work on the project. And that's Stella, who will be talking shortly, who is working with the data, and I'm doing the other stuff. Also, Ruth Goodall has started to attend our meetings, and we've had a lot of input from Alex Potts, who's in UCL Data Protection. And so we meet internally every week, and we also meet regularly with the WHO Global TB Program people, in particular Fuad Mirzayev and Samuel Schumacher. And this is the way we thought it might work, that we have the data in this thing called the Data Safe Haven, which sounds great. And we then have data contributors who possess data sets that might be of value. So we contact them, we have legal agreements with each of them, and following that, they send us their data, which gets imported into the safe haven. And we create this IPD. There are researchers who are interested in carrying out research on TB, and they see what is available, they write proposals. These are checked, reviewed by our Data Access Committee, and if approved, there's another legal agreement, and the data is released to these researchers. And I'm now going to pass over to Stella, who's going to talk about what the Data Safe Haven actually is, and how it works.
So the Data Safe Haven is UCL's technical solution for working with anything that contains potentially identifiable data from patients. And it conforms to NHS Digital's Information Governance Toolkit. It's based on the idea of this walled garden, which is a sort of a safe space to play. So whatever you're going to do in a super safe environment. And it's ultra secure. There is a multiple layers of things you need to do to be able to log in, including one-time password access, one-time tokens that you need to use a mobile phone app to generate and get in. And inside it, there's no email, no internet browsing, no personalization of any kind, and all applications in there are controlled. So nothing comes in, nothing comes out, unless you're one of the specific users that has specific permission to remove data. But other than that, it looks very much like your UCL desktop, and it's there. You just access everything, work whichever way. I open Stata windows, as many as I want, and you open spreadsheets to do whatever you like in it. To get access inside the DSH, each contributor is given a one-time, time-limited credentials to upload the data. It's really quite interesting that they put the data in, and then it looks like everything disappears. So they just go, but no, that's right. It's the data are being quarantined, and they are being checked thoroughly for malware. Once that is done, then the data get released into the DSH and work can start. And that's where I start to have fun, when you pick up the data and then you check for you validate the data, check integrity, and you all go through all the data curation process. Once that process is finished, then the data get incorporated into the IPD. Data sharing is a very live issue at the moment, and it's been agreed that the vast majority of studies that are coming up now want to share the data, and an increasing number of them are agreeing to do it. Programmatic studies have fewer constraints on them, and it's easier to share, but they're through a simple process. But on the other hand, clinical trials collect more information in a more specific way, in a more controlled manner. So they also have a completely different way of, collect different data. But the constraints on sharing the data are much bigger. So at the moment, it's only programmatic data inside the IPD. The contributors to the IPD are requested to send their data to conform to a data dictionary, so we can harmonize all the data sets. This means that we had to make initial decisions about the structure and what is contained in this data dictionary. It's also in a format suitable for the WHO guideline development. But because the contributors must fit that data into this predefined dictionary, it is a very involved process for both contributors and curator. So the entire process of putting things together is complex. On the other hand, the purpose of this IPD is to be shared with other researchers. And so there is opportunity for further development of the dictionary. And these are a few examples of data sets that we already have from the review IPD. We have 2 data sets from the 2012 IPD and 18 from the 2018 IPD. And here you can see sort of an idea, numbers of observations and locations and just general idea of it. So this data dictionary at the moment this is our first version of it, and is based on the WHO GDG. On the left, you can see that each row here is a tab in a spreadsheet that can then be further expanded for capturing all the data fields that you may want from the trials or the studies. And on the right is the demographics tab expanded, so you can have an idea about how they can be expanded inside. And in red, you can see it's one of the variables that we consider to be sensitive, and we chose not to have that anymore. Instead of date of birth, now we're going to work only with year of birth for the patients. And here you have an idea about the completeness of the 2018 data sets that we have access to. And this kind of summary is what's going to be shared with potential researchers that may want to apply to use the IPD. And we also produce then more detailed frequencies, percentages, ideas about what's happening with the summaries. Again, like the data dictionary, this is for the benefit of the researchers. They need to decide what's interesting to them or not, and what they want to see of the data sets before they apply for the use. Because it is an application process, they're going to have to write a sort of mini grant anyway. So here we are.
Governance is a big thing, bigger than I had anticipated, and it's something that we're having to learn quite fast, and interesting to hear what other people have think about this. I thought I'd just share a few thoughts on anonymization, because this is something that I felt quite confused about. You need to know whether the data are classified as anonymized in order to know how we're allowed to work with them. If you look at definitions of anonymization, here's 188 definitions of anonymization, and they're all slightly different and they're not always compatible with each other. But GDPR needs reassurance both that personal data have been removed, but also that re-identification will not happen. So, for example, even if you have data from someone without their name or their national insurance number, which are direct personal data, the fact that you know that a person attended the clinic on this date, and you know that the location of the clinic, their age and their gender, you might use those all to identify them, and you might then be able to work out what their HIV status is and so on. So there is potentially re-identification, and it's sensitive information. And every time I went through the GDPR privacy and anonymization things, it keeps on saying this is anonymized data. Maybe, because at each point they said, but you know that, are you sure? And it became really quite difficult to get a feel for how we're ever supposed to be sure that anything was ever anonymized. And they talk about motivated intruder tests and so on. So I was interested in the idea that came up more, that anonymization of data is really a risk assessment, and many of us are much more familiar with risk assessments. And I'd argue that individual patient data will, by definition, always hold some re-identification risk, because by definition, you have multiple items of information that you are linking to a certain person. So there is always this collection of data that links to a certain person. I'm then confused that you read online that organization X has fully anonymized all data, or that contributors will provide fully anonymized data, because it suggests that anonymization is an inherent property of a data set and that zero risk of re-identification is possible. And when you read the GDPR, that's never allowed, because it's always, and how do you know that you can never re-identify? So what I now think, and I feel much more comfortable with, is the idea that anonymization depends on context. So it's always the data and the context. Some of this you're very familiar with. We have pseudonymized data. Many of you work with clinical trials, and you have this situation where people in a clinical trial, their data is linked, instead of their name, it's linked to a code. And then separately, in that organization, there's a key that shows that these are actually the people who are linking to these codes. And this is pseudonymized data. However, if we take this data set without the key, transfer it to UCL, this has no key. And even though the key exists in the organization it came from, it doesn't exist here. The context is different, and these can now be classed as anonymized data. And UCL is very clear about this in their advice. Pseudonymized data without access to the key is anonymous. So that's something that I think is really useful. So here is another diagram I find really useful. It's from the Information Commissioner's Office of the UK. They've just brought out a document, how do we ensure anonymization is effective? On the left, we have data that is highly identifiable and is definitely personal data, and GDPR applies. On the right, we have data that is impossible to identify, it's really anonymous, and it's probably useless for research. So what we're really interested in is this bit in the middle. And what they say here is that if you take into account, you have data that could be identifiable or not, and you take into account the measures you're using. So for instance, the technical and organizational measures, such as the data safe haven. At that point, instead of going down this route, which calls it personal data, you can move it to the right, and it becomes unlikely to be identifiable, and you can class it as effectively anonymized, in which case data protection law does not apply. So this is what we're essentially trying to do. In our context, the IPD, we would class as being effectively anonymized because there's no overt personal data, no access to keys. We are removing the date of birth and higher risk data fields. It's held in a highly secure environment. There's only limited named access to me and Stella, and written assurances. We have written assurances that we will not attempt re-identification. So this is now, we're calling this anonymous data, but it's only anonymous in this context. That means we send it to researchers, and actually that's a different context. So it may not be anonymous there. So we then have to have some responsibility and make sure that when it goes out, that they both have environments that are secure and also have is kept securely, has limited named access, etc. There'll be legal documents signed to say they won't re-identify. And also we are mitigating the risk because we're not going to allow location information that's smaller than the country, and we're not going to include treatment dates. We'll give treatment as intervals instead, unless people ask specifically and give justification for those data. So we're mitigating the risk by reducing the amount of data and the risk of re-identification. Not surprisingly, there are related IPD ventures. Some of you may have heard of the Infectious Diseases Data Observatory based in Oxford. And since 2009, they've been doing something similar for malaria. Since 2016, they've been working with other diseases, Ebola, COVID, and so on. And we found some of their documents and governance information extremely helpful because they are posted online. The Critical Path Institute also, this is in the US, they host TB Pacts, and TB Pacts involves the collection of some TB trial data, and you can apply to them to get access to those data. So these are related. And so finally, coming to the progress and challenges that we have for this project, we have some data already, which is great. We're already also in touch with people in terms of new data that's not in the McGill data sets. We have a new name. The WHO have decided that it's not going to be just DRTB, drug-resistant TB, it's going to be all TB. So we're changing our name from the TB IPD to the TB IPD. Governance is an ongoing thing and is a lot of work, but it is in process. And our hope is that although this data keeps on changing, that we'll have version 1 live by the end of the year. And in the future, we want to think about other sorts of data, clinical trials data, pediatric TB and pregnancy data. We would like to start to get more involvement, broaden the involvement within UCL from our UCL colleagues, bring their expertise and input. Interaction and communication with the outside world, improving interaction with data contributors, asking researchers what would be most useful to them, moving into thinking about community engagement and capacity development, which was on the original call from WHO, linking and engaging with other IPDs and the wider data sharing discourse. And finally, I'd just like to thank everybody. I think I've mentioned everybody. If I haven't, then apologies to them. So thank you.
Well, Neil, thank you so much indeed. Time for one question. Then what I'd like to do is us to go 10 yards that way and carry on asking questions whilst drinking, whatever you'd like to drink. So one quick question. If not, I'm going to ask one. How easy is it to get people to contribute if they're faced with lots of issues, as you were saying about getting the data dictionary right and the quality of the data? Is that a problem? You can answer it out there if you want. You don't have to say no.
I think so. What we've seen is that I think people are quite keen to have their data have another lease of life. So I think that they are often very, very keen that it happens. But it's quite complicated. So a lot of the data sets that we've got, for instance, are from CDC. They're very keen that they've been great, actually, in terms of getting it incorporated. I think that this is not our experience, but what we've heard, reading between the lines from Dick and people like that, is that the data comes in and sometimes there's quite a lot of work for us to do. So it's not necessary. We haven't had that experience yet because we've only incorporated data that has gone through another IPD. So we haven't had the new data where we have that sort of challenge.
Which you may see with the drug sensitive data.
Yes,
that'd be huge.
Yeah. Yes, you do. Just keep you running, Mark.
Yeah, just an observation really on the CPTR data sets, which were started off with the three moxifloxacin based clinical trials. That's Remox, Rifequin, and what's the other one? Off the top, yeah. What was interesting about that was, so I think people are prepared to put data in when they think there's going to be something useful, when they can see a benefit for them to be able to compare that data. One of the things which was interesting after we'd all contributed our data, and I was involved in two of those things, was the fact that you have to let go of your data. So I was involved in quite a lot of conversations in the Remox group about people doing analysis on our data sets once we shared them, and people saying, well, have we got control over this now? And so that's one of the things people really need to think about, is if you're sharing your data, then you truly are sharing it. And you have to accept that people might do something with the data that you don't like, and you might not even agree with their analysis and how they do. So that's something to be prepared when you're discussing with people sharing their data.
very good point. Louis.
I'll let you do the walk round. Oh, yeah, there you go. I was just going to say, hopefully you'll have more luck, because most journals now insist that all data is made open access anyway, and so it's part of the requirement for publication. So that being the case, hopefully people will be sending stuff your way.
Hope so. But we've got a lot of data that's already available that we still haven't incorporated because of all the systems we have to set up. Should we finish?
Yeah, I think so. So just before we head that way, I'd just like to say thank you so much to our speakers, to Louis, to Connor, to Stella, to Neil, to Eloise and Hanif, and I suppose me and Lele, and all of you for taking part in this. This is great. It's first of many. If there's things, by the way, if people want to get up, because this will be very informal, so if you want to do a presentation, I'm not looking at anyone in particular, but then please, use this as a forum to, as Louis says, try stuff out, and there'll be friendly, kind questions, but always good. So thank you so much. Thanks, Neil, for sorting out all the recordings and so forth, and let's prepare that way. Thanks, everyone.